but that's what it is that health funding is influencing the structure and the organization of the entire healthcare system. And this is what I think we should think about it. Just think about it a bit. One sector, private health sector, treats healthcare as a commodity. Okay, you have to buy it like we're buying a hamburger there, because that's how you are treated, in a public sector. And then you have the public sector, which tries, seeks to pursue, the healthcare as a right, to treat healthcare as a right. We have not been, much more effective, but that's our basis, to promote healthcare as a social right, in line with the constitutions, where access is not dependent on whether you are employed or you are not employed, or how much you earn, So yet, if you think about that in a situation where resources are concentrated in the private sector, you wonder why the public health sector have seen a shift of resources over time. There's a very rich studies that have been done that shows how resources are moving from the private sector from the public to the private. So we increase. We said, okay, there are vacancies. Okay, so we put people there, doctors, specialists. Within a few years, those doctors go back to the private sector, because that's where money is, that's where resources is. So the point is to show that you are dealing with an unequal, but it's the same system, but largely dominated by market forces or the private sector. And no wonder, we still continue to face systematic crisis. This is very, very important, even from the debates of our detractors, especially opposition, who always say, fix the public sector, and then you can think about anything later, okay? So what they basically means is that you keep on trying to address the public sector. I'm not saying all the problems of private sectors can be effectively addressed without looking at the system as a whole. I mean, there are other, basic things that we can begin to address. But a lot of systematic crises affecting the public sector have much to do with the whole system. Have to do with so you can't touch the public sector without touching the private sector in terms of radical transformation. And I think what is a consensus within our alliance and so on is an appreciation of that, a growing appreciation of that you cannot deal with that if the private sector continue to command huge resources of healthcare as they do now. So I just wanted to point that dialectic, that it's a contradictory dialectic, and it must be resolved. And then I think the NHI, it's an answer to that. We need to deepen also, I wanted to say and argue, and just, to say that we have to strengthen our class perspective, to healthcare, and basically, to not only see reality based on race, which is very, very important. I'm not disregarding, belittling the racial reality and the gender reality, but that it must be basically, we look at it on the basis of class, and because class, it's a very, very powerful category of analysis as Marxists, as socialists, and as communists, that we understand society and its health system, and I found that in most cases we lose sight of this dimension, an important dimension, because how we live, where we live, how you get sick, how you die, it's not just based on race and gender. It could fundamentally based on race you belong as well. So so from the point I've just made earlier that our two-tier healthcare system is organized in such a way and funded in such a way that those with less need, as I've shown with those resources, because largely people who are wealthy, who are rich, they don't need much of healthcare. So their health needs are very, very less. It's a basic understanding that those who are mostly likely to need of healthcare services and resources are likely to be, and are largely, the poor and the workers. So from that point of view, we can conclude, therefore, that our entire healthcare system is organized in such a way that it benefits, the corporate elite. Okay, and then the last part I wanted to talk about is some of the principles of NHI. I didn't include them. That, before I go into the picture of, I wanted to argue that some of these principles of universality and social possess a very strong class content to them. Okay. I remember there was a debate about the principle of universality, that, but, not everyone, there are rich people out there, should they also enjoy national health insurance? Why don't we look at, those who are the poorest of the poor and focus NHI to those and leave out those of the class, even they are working class, but they earn better income, should not be, so it's, and yet, our own experience, with targeted means of care, as well as in international experience, shows that universality is a much more stronger principle to organize society and to change society than a targeted means, especially when this targeted means will imply that you have to have this huge bureaucracy behind you, to say, are you earning this much? Oh, okay. Or are you earning? So you have to do all these things of bureaucratic red tape that ended up not addressing healthcare, but addressing non-healthcare resources, which is also a response to today's present healthcare system. Our healthcare system now, the one that is dominated by private sector, is at 10% of that amount in the private medical scheme is spent on things that have nothing to do with healthcare, okay, leave alone profits. But huge, you've got brokering, middlemen in, you've got different administrative groups, each with their own forms of management and all those kinds of things. And all that money, then they call it management fee. Okay, all that money ended up not going to the patient. So for every 100 rand I pay from a medical scheme, know for sure that probably 10% of that, 10 rand and whatever will go to the others also. I'm not even counting those that goes to other middlemen, and they are, of course, they are men in the process, like brokers. There are these people called brokers who negotiate on behalf of insurance companies. So universality is also in an attempt to address administrative nightmares that people who experience medical aids, especially providers, a lot of doctors are complaining, for instance, that they'll have to wait for 1 month to receive a bill, they have sent to, Discovery or to MedScheme, because they have to approve those first before they can continue providing further service. So from their point of view, this bureaucracy is also undermining their capacity to provide a better service to patients. And social solidarity, I think this is very, very important, and is inherent in a working class tradition. And in the context of healthcare, it's not just in class solidarity, where the workers who have got medical aid enter into solidarity with the rest of the class. It is also solidarity, from a health perspective. Those of us who are sick, can only sustain ourselves by those who are healthy. Okay, so there is a cross subsidization there, even from a health perspective. The young and the old, the elderly needing more care than the young. So it's that principle that after long battles, around NHI, we managed to secure. There's also another perspective which is linked to the both one or two of treating people according to need, and not according to ability to pay. Okay. It reminds you of Karl Marx manifesto on what, the definition of what socialism or communism should be all about. That it is no longer based on your ability, but it is based on your needs. And in this case, in a narrow sense, of course, is that it's not based on your ability, whether you've got money, you can purchase those services. But that, you need healthcare, so you need to be treated as such. It's another principles I didn't mention here, but I thought it is important. Okay, now let's go to the issue of COVID-19 and the future of things there. I thought of sharing with you, the grim data that is out there, but I thought I left it out and just talk about, what other countries out there are beginning to do to respond to the COVID in a way that, you would have thought it was not thinkable. It's not possible that countries can go to those to that direction. I mean, I'm talking about countries, largely even center-left parties, where there are center-left parties, or moderately, social democratic, you find a very, very interesting responses that are pushing, that are either strengthening their health systems, or they are also transforming them towards principles of universality, social solidarity. And another important point to look at is that many of these responses came right at the moment when the spread of the virus was basically getting out of hand. Okay, and threatening, their own existing healthcare systems. We must remember that, for instance, in countries like Western Europe, where they do have universal systems, they don't have, say, for instance, like Cuba, where universal systems also have got a primary healthcare as their base. So they are a hospice-centered. So their experience and capacity to respond to COVID, which requires a lot of prevention, primary health care, interventions, have been found wanting. So I think we need to take that into account, that part of the existing healthcare capacity may be, for instance, that the healthcare system is not rooted at the base, at the level of the primary healthcare. So for our case here at home, I think, in various degrees, we really need to look at the timing. We have looked at the timing very, very early, that, okay, through lockdown, we can have a marked time to build our capacity, okay, of building community healthcare, primary healthcare. For instance, the ANC manifesto suggested 50,000 community health workers in 5 years. Well, we did that in 2 months. Okay, 2 months we did that. We had more. In fact, even we're still even employing more of these community health workers, which have been very critical in doing screening and referring people for community testing. Okay. I think today's numbers are talking about probably we are going to 2 million of people who have covered so far, or more. So it's quite an effective community-based responses and so on. And the lessons of China and to a certain extent even in Cuba, where we have seen what they call this Committee for the Defense. I think that's what they are called in Cuba, but mobilized just to promote prevention has been very, very critical to that. Capacity at the level of beds. Now, we may think of beds in general, that every hospital bed is critical for COVID, but a lot of COVID patients may need a lot of what they are there when they are admitted is largely for ICU cases where they are actually critically ill. So they need ventilators, they need oxygen, and things like that. And our public hospitals, have not been enough for us to meet that. And I think increasingly we're becoming aware about the importance of mobilizing the whole of the country's healthcare resources, including many of the ICU beds that are concentrated in the public sector, private sector. Private sector has got lots of these ICU beds and so on. Issues of staff, I've already talked about that a lot of the doctors we need are actually in the private sector. Okay, this issue of ventilators and so on. So there's some progress, but I will not say that progress, it leaves much to be desired, especially along the level of pulling the doctors into the system, resources. There are several key issues. I'll talk to them later in the end. But that's what the experience in other interventions have shown, where states have taken emergency measures in other countries to incorporate private sector capacity in one form or the other. Some include even actually visual or partial nationalization of hospitals, of private sector hospitals. Some have involved, public control over the use of healthcare resources, not just in the public sector alone. And what have we done other than what I've just described a bit is that the declaration of the national disaster had some elements that enable, for instance, the Competition Commission to say, okay, National Department, we empower you to interact with the stakeholders for purposes of promoting some agreements to promote access to healthcare, but also to reduce prices in the fight against COVID. So there was a wide-ranging, significant powers that the the Competition Commission regulations have given to to the National Department in particular. And but so far, the interventions that we were able to see are have not been effective. Have not been effective because of the fragmentation of healthcare funding, including procurement. Is still a real issue. I'm not just talking about the private sector, but also within. So in other words, if we want to procure critical, masks for our health workers, the PPE, as we call them, the personnel protective clothing, equipment, all that requires, that you have the center coordinating that procurement. But as the situation it is, every province is doing that. They are even competing for this, in a world where there is a very, very, a jungle out there, very, very chaotic, scramble for these resources. And we are doing that individually, each province trying to do its own, competing for this piece. Actually, there is one province that has got almost 80% of the stock of some of these resources. So you could just see how the approach at the national has not been effective in coordinating the healthcare resources. But if we are to adopt, I will say, an NHI style approach, it will be that it should be the national that secure these procurements, and that can be enabled, of course, by the Disaster Act provisions to empower the minister to do just that. But it's a question for discussions as well. So here I've just outlined some of the interventions we can look at that, and some of them I know that they're already there in one way or the other, but as I was saying, they depend on some kind of an agreement, a voluntary agreement with the private sector. And as the crisis of the pandemic deepens, I'm not sure whether we can just rely on a voluntary agreement. Because the most effective way is to intervene decisively and basically direct where investments, where staff should be redeployed, and so on. So bullet number one, just talk about, how do we secure, the private sector hospital capacity, which I've explained is very, very well resourced when it comes to ICU beds, and doctors and things like that. Currently, there is an agreement that all patients treated, public patients can be treated in the public service, but in the private sector, it's an agreement. The problem with this agreement is that it's still going to differentiate. So if you talk from the principle of universality, is that still going to prevent that I'm a private patient because I've got medical aid and you are the public patient. So already creating a problem of stigmatization and potential discrimination of patients and so on. And the point we are making now is that perhaps we should talk about all patients be treated, as public patients, whether you've got a medical aid or you don't have, and so on. And I must also, I just had a discussion with my colleague, Dr. Aquina, who sits in the Council of Medical Schemes. She tells me that actually there is a strong lobby from the private sector to actually raid even basically under the name of bailout, because as they are not making money during COVID, they want to use medical aid reserves, which are legally required to have reserve of about 25% or more. Now they want to raid those worth about 60 billion in the name of that they're not getting enough income as they used to get under in pre-COVID era. Now, that could be one way in which we can even begin to respond to that along the NHI lines, from my point of view. And I think this idea of treating patients differently, where others are used, where as private patients or others are public, is very, very problematic. Some international experience shows that private sector can actually can be forced basically to work on a cost only model, meaning you charge people on operation costs or on a nationally agreed tariff, which means what we charge people in the public sector for services, we can do the same in the private sector during this moment. I think that already some private sectors happen to agree with that, but I think it's how they calculate the formula of a cost. I mean, how do you charge someone? How do you pay? Because public patients have to be paid, and how do you differentiate a JSC listed net care company that makes lots of money, lots of profits, that they have charged such a person not on a profit basis, but on an operational cost basis. So this is very, very important to consider. The most critical one is the one of specialists. I think this is the most difficult one. And as you know, specialists have been even much more reluctant to explore new payment mechanisms. But already in COVID, there are possibilities for us to see in what way we can engage them, either by carrot or to a certain extent, even by a stick, to shift their services away from the wealthy parts of our cities and towns and much more where they are needed. And I think this is very, very critical because COVID pandemic differs. It can be a pandemic, an epidemic here, epicenter here, tomorrow here, and later there, and therefore it requires movement of our human resources. But as currently, this fragmentation that exists, where provinces are doing these things without national coordination, can undermine the deployment even of doctors in the private sector to the public sector. So these are points I wanted to talk about. And maybe I can leave it there, and I hope I've done justice. But this is what I thought I should reflect on these issues. Thanks.
No, you've done more than justice, Comrade Tebogo. That was a really brilliant, very brief but really brilliant input. I really appreciate it. Learned a lot from it. Okay, so what I'm doing is I'm asking for comrades to put up hands and